Assalamu alaikum. Let's start our today's session. We have patient Mr. Ahmed, 29 years with abnormal movement. We will start now. Start sharing the timer. Just a second, please. Okay. Yeah. So you can see the timer now.
Yes.
Yeah. You can start, please. Hello?
Hello?
Yeah,
Yeah, you
hello
can
there.
start.
Okay. Hello there. I'm Dr. Zain, one of the doctor at the clinic. Is it Mr. Ahmed, 29-year-old?
Yes, doctor.
Yeah, we are here to assess you, taking history, and after that I will examine you. Is that all right?
Yes, doctor.
So what the problem?
Doctor, actually, I had abnormal hand movement in both hands since 1 month.
Mhm. And have you got it before this 1 month?
No, doctor.
And started all of a sudden or gradually?
Gradually.
Is it increasing, decreasing, or on and off? Or the
Yes,
same?
doctor, increased.
Okay. And do you have like any special situation that increase your movement, like being stressed out or something?
No, doctor.
Okay. Is it this hand movement increase when you like stretch your hand or when you are at rest?
No, doctor, the same.
The same. Okay.
Mhm.
Does anything in particular decrease it?
No.
Okay. Okay. Does it decrease by alcohol?
No, doctor. I do not drink, doctor, alcohol.
Okay. Is it in both hand or one hand?
In both hands.
Is it in both hands? Is any area in your body like moving, like your head, your foot?
No, doctor.
No. Okay, okay. And is there any pins and needles in your hand?
No.
Do you have any kind of weakness?
No, doctor.
Okay. Do you have any headache?
No.
Any vision problem?
No.
Okay. Any problem with your balance?
No.
Okay. Do you have any change in your voice?
No, doctor.
Okay. Any difficulty of swallowing?
No.
Okay. Do you have any problem with controlling your bowel or water
Bowel.
work?
No, doctor.
Okay. Have you got any kind of trauma to your head before?
No. No.
Okay. Okay. Then do you have any kind of weight changes?
No, doctor.
Any increase in your body temperature?
No.
Any lump or bump in your body?
No.
What about your mood?
There's no any problem. Is it okay?
Okay. Okay. Do you have any sweating?
No.
Okay. Do you have any any cough?
Cough? No.
Any shortness of breath?
No.
Noisy breathing?
No.
Do you have any yellow discoloration of your eyeball?
No.
Okay. Any tummy pain?
Sometime.
Where exactly, if you could point with one finger?
In all my tummy.
What the nature? Is it like colicky or like a cramps? What?
Dull aching.
Is there anything does it goes anywhere?
No.
Okay. And for how long you had this?
Since long time, doctor.
Do you have any change in your bowel motion?
No.
Any blood coming from your back passage?
No.
Do you have any change on your water wall? Like become frothy?
No, no, doctor.
Do you pass any kind of gravel?
No,
Any change in the amount
no,
or frequency
no.
or color?
Or what?
Or color?
No,
Do you have any chest pain?
no,
Heart racing?
no,
Feeling dizzy?
no,
Okay. Joint pain?
no,
Any rash?
no.
No. Okay. Then I would like to ask you, do you have any past medical history that you would like to tell me?
Like what, doctor?
Like a gland problem,
Gland problem? No, doctor.
any asthma?
No,
Do you have any weather preference?
no, doctor.
Do you have any history of surgery?
Yes, doctor. Since 2 months, I do kidney transplant.
You did a kidney transplant.
Mhm.
Okay. And are you following up?
Yes, doctor.
What's your medication list?
Steroid. Some medication is the called steroid, and other medication is the called tacrolimus, and other medication is the called cyclosporine.
Is there any changes in the doses?
No, recently the doctor changed the cyclosporine to the tacrolimus.
So instead of the cyclosporine, now you are using a tacrolimus.
Yes.
Okay. Do you feel sick?
No.
Throwing up?
No.
Do you have allergy to any medication?
No.
Do you have a high sugar?
I do not checked.
Do you have any muscle pain?
No.
Okay. And do you have any family history of similar condition?
No, doctor.
Or family history of note that you'd like to tell me?
No.
Okay. And what do you do for a living?
I'm a teacher.
Teacher. I'm afraid your symptoms had affected your life and daily activity.
Yes, doctor.
I'm going to involve the social occupational worker for this regard, if you don't mind. Do you smoke?
No.
Do you drink alcohol?
No.
Do you drive?
Yes.
Okay. Then I would like to examine you. If you feel any pain or discomfort at any point, just let me know. And I will also ask you a few questions if you don't mind, okay? Vital sign.
Vital sign normal.
Okay. Then I will go to his hand.
There's
Yes.
tremor, bilateral hand tremor.
Is it like when he stretches his hand or like resting or what?
Yes, increase it.
When he stretches his hand?
Yes.
Okay, I can also put a paper above his hand to make the tremor more clear. Then I will ask him to poke back his wrist. Is there any flapping tremor?
No, there's no any flapping tremor.
Any clubbing, euchonychia, cholinergia?
No.
Any needle mark? Needling?
No.
Okay. Then any pulmonary edema?
No.
Okay. Then I will go to his pulse. Is it regular?
Yes.
Any collapsing pulse?
No.
Then I will check for proximal myopathy. Any proximal myopathy?
No.
I will check also in the forearm if there is any kind of AV fistula.
Yes, there's fistula.
Then I will. Is there any thrill above the fistula?
If there's any what?
Thrill?
No.
By palpation? Then I will scalpel for bruit above the fistula.
No. No thrill and what?
Bruit.
Yes. Mm-hmm.
There is pruit when auscultation of the fistula.
No, 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 no,
Is there any recent needling?
no.
And then I will go, the patient is lying comfortable at bed, am I right?
Yes.
Like not tachypneic or something. Then I will go to
Mm-hmm.
his face, any pallor or jaundice.
Mild pallor, but there's no jaundice.
Okay. Mr. Ahmed, do you have any bleeding from anywhere?
No,
Okay. Then I will go for his face, any hypertrichosis, like any increased hair in his face.
no,
Okay. Then I will go for his mouth, any cyanosis,
no,
rash,
no,
or there is any gum hypertrophy,
no,
tonsils enlarged or not.
no,
Okay. Then I will go for his neck, any lymph node,
no,
thyroid, by giving patient water to take.
no,
Any raised JVB.
Mhm. No,
Then I will go for his chest, any scars, gynecomastia.
yes, mild. Mm-hmm.
There is what?
There's gynecomastia, okay.
Okay, Mr. Ahmed, is it tender?
No,
breast?
no,
Then I will press any like
no
masses
need,
and something.
no
No
need,
need.
no need. Mm-hmm.
Okay, okay. Then I will check for what any you said no scars, nothing, no central line, no portacath, nothing.
Mm-hmm.
Okay, then I will hear the by auscultation heart sound, any added murmur or sound.
Normal. This one is too audible and there's no
Okay.
murmur.
Okay, then I will check the basis for any crackles.
There's no crackles.
Okay, and then I will go for his abdomen.
Mm-hmm.
For his abdomen, like, is there any scars or any BD
Yes,
cath or
there's
something?
there's a scars. There's a scar for
Yeah.
right iliac fossa. Mm-hmm.
Okay. Okay. Then is the if the abdomen is like full flank and distended or not?
No,
No. Then by so do you have any pain at all in your tummy now?
no, no.
Okay. Then I will go for superficial and deep palpation.
Mhm.
Okay. Then I will go for the mass. Is there any tenderness above the mass?
No,
Okay. Then by hearing the mass, any kind of pruit?
no. There's no bruit.
No pruit. Then I will go for the liver and spleen, any organomegaly.
No.
Okay. Then for the kidneys, are they bloatable?
In other side,
In the left side, bloatable.
left side.
Is it
Mhm.
is it nodular?
What?
Nodular, like nodules, like when I pressed,
No.
when I palpated?
No.
Okay, and what about the right side? Is there any scar or just not palatable, not palpable?
Just only scar for right iliac fossa. Behind the
Oh,
scar, there's mass for kidney transplant.
okay. Then I will hear for renal pruit.
There's no bruit. Mhm.
No pruit. Then I'll go for.
Mhm.
Do you have any pain at all at your leg?
Pain where?
Then
Neck?
do you have pain at all at your leg, Mr. Ahmed?
No. No,
Then
no.
I will press for lower limb edema.
There's no lower limb edema.
Okay. Then I will ask you, what's your concern?
I want to know what I have.
Yeah. I appreciate your concern after assessing you, Mr. Ahmed. I think you have got a side effect of one of your medication, most probably the tacrolimus that you are taking, causing you this handshaking that you have. And I want to ask you when the tacrolimus is added exactly.
Yes, before this complaint, before the hand tremor.
Okay, then what we need to do now, that we are gonna involve the kidney doctor, and we will see the drug level, and we will check more your kidney function also. And we will involve the occupational social worker for you, if you don't mind. Do you have any kind of other admission? Do you have any kind of other concern?
No, doctor.
Okay,
Doctor, you
good.
want me to stop this medication?
We need to see the drug level first, and we can. It doesn't really need it to be like to be stopped. It might be
Okay,
we
time
make a
is up.
modification for the dose.
Okay.
Okay.
Okay, time is up. Let's go to
Yeah.
the examiner. Time.
Okay.
Okay, start now.
Okay, what's your differential diagnosis?
First differential could be a medication side effect. Second differential, it could be like an anxiety. Third differential, it could be anxiety medication side effect in this patient in particular. It could be like hyperthyroidism, but again, it's this I couldn't appreciate any sign or symptoms of hyperthyroidism. Yes. Other differential, it could be like essential tremor, benign essential tremor, but again, it's this his tremor doesn't like relief by alcohol, and he has no family history, and it is mainly localized at his hand. Yes, these are my differential.
Okay. Why this the patient is not Parkinson?
First, it could be like regarding the idiopathic Parkinson, because of his age, it could be like a Parkinson plus. But again, it's this, he has no like a balance problem, and he has no dizziness when he stands from a sitting position, like to rule out a Parkinson plus. And the tremor itself is not at rest and not a bell rolling type. And he doesn't have like any kind of jaundice, like to say he's a Wilson disease one. He doesn't have like any behavioral problem. Yes.
Okay. Did you check the tone of the patient and the gait?
I should really check them. You are right. Yes.
Okay. Okay. How to investigate?
Okay, apart from the basic lab, inflammatory marker, I will do drug level for the tacrolimus. You will check all the chemistry, the basic lab, like including the CBC chemistry panel, including renal function test, electrolyte. As we said, the drug level and the thyroid function test. What else? We can do like what else? Drug level, ultrasound for his kidney, urine analysis.
Does the patient had any sign, any sign of symptom of kidney reject or not?
The patient doesn't have like a tender kidney, and on examination there is no like recent needling for the fistula, and it is not functioning, and he doesn't have like any sign of fluid overload or uremia symptom. So I think he doesn't have like any sign of kidney rejection, and he doesn't have like any nausea, vomiting, or a decrease in urine output.
Okay. Okay, if the patient come with acute severe abdominal pain, what's your differential diagnosis?
In this patient in particular?
Yes.
It depends on the size of the pain, the site of the pain. For example, if the pain in the right iliac fossa with a severe pain, first I will put like a kidney transplant rejection, or it could be like in this patient, or it could be like a side effect of his medication. what else? It could be like severe abdominal pain in a kidney transplant patient. Where exactly the pain? Like
At the site of the scar.
at the side of the scar?
Mm-hmm.
It could be like a rejection, or it
Mm-hmm.
could be like appendicitis, simple appendicitis,
Mm-hmm.
or colitis, or a thrombosis at the side of the the side of the kidney transplant.
Okay. What
Yes,
investigation
or he got trauma.
you wanted to
Yes.
do? Mm-hmm.
Huh?
What investigation you wanted to do?
For the severe abdominal pain, or for this
Yes.
patient
Mm-hmm.
in particular?
For severe abdominal pain.
For the severe abdominal pain, if this patient presented with severe abdominal pain, we will do a basic lab, inflammatory marker. Basic lab, as you said, including CBC, chemistry, pattern, including renal function test, electrolyte, liver function test, coagulation profile.
Single important test.
And okay, we will do ultrasound Doppler.
Yes.
Yes, to rule out the thrombosis inside the transplant.
Mm-hmm.
Yes. Of course, we will do like a urine analysis. Also, yes. That
Okay,
is the
time
thing
is
that I
up.
will do. Okay.
Yeah, thank you, Dr. Rada. Well done. Thanks, Dr. Rasha, for the case. Can you comment on here? Then we will continue.
حاجة first of all الكيس overall كويسة، بس الكيس يعني أنا قدرت هيك sudden not prepare. بس يعني أنا بس حبيت إن هي تدير exclude the other cause of abnormal hand movement، وهي الدكتورة دارت يعني دارت الهايبرثيروديزم، الفيبروميسيتوما، الفاميلي هيستوري اوف essential tremor، الباركنسون. بس ما في أسئلة بتاعت الباركنسون ما سألتش عليه هنا. difficult to initiation the movement, loss into the arm swing، الاكزامينيشن لو كان في cogwheel rigidity، الابنورمال speech، الابنورمال gait، فكان important to rule out الباركنسون. السي ان اس مهم عشان to rule out cerebellum lesion اللي هو الويكنس والهيدك والبليرد فيجن بتاع الهاي انتركرينيال بلاد بريشر. الويلسون اوكي يالو اي discoloration excluded overall كويس يعني. تمام.
Okay.
Yeah.
Regarding this severe abdominal pain.
regard severe abdominal pain عشان to rule out إن هو kidney reject، وفعلا السنجل test is most important الدوبلر ultrasound.
Okay.
regard severe abdominal pain this patient ممكن التاكروليمس يدير most common cause، يدير tremor ويدير GIT upset.
Okay. And do we need like to stop the tacrolimus or just to modify the
Yes.
dose?
To need to stop and a side effect I think to change it to the other kind.
Thank
you. Sorry. Yes, thank you, Dr. Rasha. Thanks, Dr. Ruda.
Okay.
Will perform as usual. I will answer the last question. So I will hold till I will manage with my specialist doctor for the renal transplant team. This is the best answer. You will hold until be reviewed by the renal transplant team. So it will not be.
Review.
Yeah. So you will be safe, and in the same time you didn't continue. But your decision is at all not your decision. This is the renal transplant team decision. Even practical wise, any patient will come with renal transplant. This kidney is very precious for them. If you stop such medication, he might have rejection. If you continue, he might have sepsis. So what the best balance action to do is to involve both infectious disease team along with renal transplant team. In this way, you will be safe. Either patient had seizure, have a sepsis, he will be managed with the ID. Have a rejection, he will be managed by transplant team. So don't do it by yourself. This is for the last question, but I will start for the comments from the start. The onset course duration about this complaint, you did it great, Dr. Ruda. What improved, what worse? Yes, okay. And the timing, then directly you ask about the CNS. I like this way to ask because this is maybe related to CNS. The vision, the pins and needles, the balance, the voice, the swallowing, the control of bowel, any trauma. All this question was or were wise question to ask. For the Parkinson, I will not think about Parkinson in such age unless, yeah, I found these tremors, as Dr. Roda said, the rolling, there is rigidity in the examination. So at that time, immediately, I will ask about Parkinson plus. But from the start, with this age, I doubt the patient will have Parkinson plus, unless there's family history. Okay, let's go back to the history: cardiovascular, chest pain, heart awareness, heartbeat, chest, cough, noisy breathing, all system review done as a quick review by Dr. Oda. It was great. The GI, when you ask for the GI yellowish of the eye and tummy pain, you should write in the side liver and Wilson, and you can put it in the differential, as well as you will do examination of the liver, complete examination of the liver. I will tell you later in the examination, yeah, what you could do. The bowel habit, the bowel habit, and feeling sick, throwing up, you ask later. Okay, genitourinary, you ask for the changing of the color, amount, and frequency. But I guess Dr. Rasha said no change. You mean that the transplanted kidney is functioning well. So still there is possibility of rejection, but at least the change will be in the color, will be in the amount, will be in the frequency. I'm not sure. You can update this question later. The joint, the skin, the muscle, you ask all these questions, Dr. Ruda. Family history, very important. And you ask early about alcohol. Did alcohol improve this? And she denied. So it's not essential tremor, or mostly it's not, but because alcohol, yeah, might be, but it's not necessary. Maybe he has not improved with this alcohol. Travel history, you missed medical history, and you got the surgical operation of kidney transplant and steroid, tacrolimus cyclosporin medication. And importantly, you ask about the tacrolimus starting time. And it was late question, but at least you asked because it was related to our case, because the symptoms started after tacrolimus started. And you can ask about the compliance and ask about the dose. You missed totally the HIV risk. I mean the sharing needles. For what? For hepatitis. Because you have a patient with might be liver disease. Might be, because still the jaundice might be related to that. So sharing needles, blood transfusion, tattooing, piercing, all these could be related to HIV or hepatitis due to either risk, recreational drug sharing needles. You don't know. And he's young. You can ask about sharing needles and the partner, casual relationship, and so on. Okay, so this is the only missing part. In the examination, you did everything, but you missed the liver, chronic liver stigmata, chronic liver disease stigmata, caput medusa, and any gynecomastia was there. You didn't ask about the axillary hair, the lymph nodes. You could ask about these things together with gynecomastia. You found gynecomastia. So check other chronic liver disease stigmata. Okay, caput medusa and the spider nevi, as well as axillary hair and lymph nodes and the liver itself, and ascites, very important, the ascites. Then you ask for the kidney, palatable, the transplanted one, how is it? And any tenderness, vital, the tremor itself, you analyze and you examine it well. Is it with the stretching? So by the tremor examination, you can rule out Parkinson. Okay, then the pulse, fistula, yeah, good. You asked about the fistula and functioning of the fistula, the face for pallor, gum hypertrophy, very important, and you did it. Thyroid, you did it. the only thing you miss, Dr. Roda, in the examination, the chronic liver disease stigmata. Just to rule out Wilson or hepatitis and risk of hepatitis in this patient.
Yeah, and also the
Okay?
CNS exam. يعني at least I should do like Dr. Rasha said, like I should do like a tone power reflex at least,
Yeah.
like a pronator
Yes.
drift something, rigidity.
Yeah. Yes. It's important in Parkinson. Rolling, rigidity, cogwheel, and the tone will be also presented in this patient if he is Parkinson. I doubt if this patient is Parkinson because of the age. But anyway, you can do it rapid
Parkinson plus, I
examination.
mean,
Yeah, Parkinson plus. Okay.
blood pressure sitting and
The
standing, yes,
supranuclear
cerebellar
pulse. Yeah.
sign, yeah.
Yeah. But you asked for the balance, so it wasn't there also. So our differential, let's talk about differential. So drug induced related to tacrolimus, but rolled out by the gum hypertrophy, but might be also cyclosporin. So what's your investigation? Drug level, as you said. Okay. Chronic liver disease, very important. Tremors in the chronic liver disease. It's important. Might be related to either risk factor or risk habit or hepatitis. You don't know. Maybe travel history. You didn't ask about travel, HIV, hepatitis. Sorry, hepatitis A. Because of the jaundice. Once you have any positive finding, don't leave it or don't think about it lightly. Think about it seriously. Jaundice and gynecomastia. You have a hint for chronic liver disease. Put it in the differential. Either chronic liver disease due to infectious or due to Wilson. However, he doesn't have family history, but Wilson is autosomal recessive. It might be not positive in his family. His parents will be carriers. And the third differential kidney rejection or kidney failure after rejection or infection, you don't know. Might be rejected, might be infected, thrombosed, whatever what happened. But this is the three differential in our case. Essentially, you cannot put it. Parkinson, okay, I agree if you have some association or plus symptoms. However, you didn't do examination, but still the patient is young. You might put if you have some vision problem, but in your case, you ask good history about CNS. I will not put supranuclear, sorry, I will not put Parkinson plus. You ask for the vision, nothing affection. If there is Parkinson supranuclear pulse, he will tell you, I can't see while going up, going down, climbing the stairs. For the balance, you ask for the balance to roll out the other. What's in the cerebellar in this Parkinson plus? Sorry, remind me, Dr. Oda.
I think there, yeah, we'll check like the
Yeah,
cerebellum and the
yeah,
autonomic symptoms and the
yeah,
vision.
multi-system atrophy. Yes, I'm remembering
Yeah.
the name of the plus. Yeah, multi-system atrophy. Yes, and the dizziness, posture hypotension in multi-system atrophy as well. Impotence you can put in this patient also if you want to ask about multi-system atrophy. Okay, in general, you did great. For me, I think you did great, and you might have the full mark in this patient. You didn't miss a lot of things, only the chronic liver disease stigmata. So let's read the comments. The renal vein thrombosis, one of the complication. And the timing, Dr. Roda, you didn't ask when the kidney transplanted. You asked, it's very
No,
important.
I haven't asked. Yes, I haven't asked
Yeah,
the
yeah,
doctor. No,
yeah, it's
I
important. Yeah.
should ask.
Thrombosis. Yeah, anything positive, write it in the paper. You have a paper, write it, make a big circle, and try to make it like stress on this finding. You ask about the timing. Was it eventful? Any complication happened like that? Okay, thrombosis, uremia as differential for tremors. Yeah, uremia the same as kidney failure and rejection, either failure or rejection. Also CNS missed. Yeah, Dr. Roda. Yes. Okay. In general, really, Dr. Roda, you did it great. I believe you can take the full mark in this patient. Very nice performance. At the system review and as social occupational, yes. Driving, you ask for driving and you just say, you just hear it's positive. Yes, I'm driving. Then what's your advice? Either to ask here, did that affect your driving? Did this tremor affect your driving? or
Yes,
to
I should
advise her.
ask. Yes,
Yeah,
I should
either
ask.
to ask or to immediate advice, but to know it, to have the data and don't give her advice means that it's against the welfare. So be careful about these things. Whenever you have positive finding, do a circle around and immediate either ask or advise or examine I mean in the history. And while presenting the case at the end, when you make a circle, you will remember what? You will remember the examination. This is an important point. What you will remember else? In the differential, when you look to your paper, what I can put here, what I can put here. Yeah, I put circle around, for example, the gynecomastia. So I put chronic liver disease. I put circle around the tender mass in the iliac fossa. I will put rejection. That's it. Okay. And yeah, and in the presentation as well, you can remember what the patient had because you might forget most of the positive data while presenting to the examiner. I have this patient with blah, 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 blah. You missed that he has gynecomastia. And after the exam, oh my God, I found this patient was gynecomastia. Why I didn't say to the examiner? You should impress the examiner by your finding, either by examination or history. And simply you forget because you didn't remember it because of the stress. But when you write it and circle it in the paper, even the examiner will ask you, what else? What else? You will look to your paper and he might ask you, show me your paper. Whatever
And
you wrote, he will see.
and
Yeah,
why this patient has gynecomastia?
yeah, this is the point. Might be chronic liver disease due to either infection or related to Wilson disease. This is one. This is my guess, but Dr. Rasha can answer us if there is something hidden in this
Yes,
patient.
also, and in the chronic kidney disease, patient may have chronic kidney disease.
And Dr. Rasha,
Yeah, as
I think we
androgen,
put,
you mean?
yeah,
Yes.
I think we can put in the differential the uremia itself. It can lead to tremor. It should be like in the up. Am I right? Like
Yes,
a drug level,
but the patient,
uremia.
uremia conscious, oriented, communicated. There's no any GIT upset. There's no any vomiting.
Yeah, but I can choose
Yeah.
it. It should can put it like above.
Uremia, I think renal failure, flabbing tremor.
Okay.
Yes, yes. For flapping tremors. Yeah. But whatever flapping or fine tremors, still you can put it's you will say, but against that it's fine. Against that it's but it's still in the at the end both of them or all of them are tremors. So from where you will get another definition? All of this can be as differential. For me, drug-induced chronic liver disease, kidney rejection, and uremia as a complication of kidney rejection. So if any question or any comment, I guess we did this case successfully. Thank you, Dr. Rasha, for the case. Thanks, Dr. Ruda, for the performance. Let's shift to the next scenario. If no,
Okay, I will write the scenario in the chat box. Dr. Rasha, it's in the chat box.
Yes, okay. Give me 3 minutes بس.
Dr. Basim.
yes,
Hello.
sure.
I will send the picture of the rash to your WhatsApp.
Okay, I will share it while presenting the case. Okay, thank you.
Yeah, I can start.
Okay, I will share the timer.
Mhm.
You can see the timer?
Yes.
Yes, Dr. Huda, ready?
Yeah.
Okay, start.
Okay. Hello, good evening. My name is Dr. Al-Mahdi. I am doctor in charge here today. Can I confirm I am talking to the Mr. Omar?
Yes, doctor.
Okay. Are you 40 years old?
Yeah.
Mr. Omar, we are here to discuss about your health status, and after that, and examine you and address your concern. That's okay with you?
Yes, please, doctor.
Okay, I received a letter from your GP states me that you have skin rash. Can you tell me since how long you suffer from that?
Yes, doctor. I have this problem for 4 months now, and I think it is like becoming more larger, doctor.
Once stopped, it was sudden or gradually?
I started gradually, actually,
Is it increase or decrease or the same?
increasing, doctor.
Is it the first time or you had previous attack?
Yeah, doctor. I had previous attack, but they healed. They healed successfully, but I think this one is getting larger, doctor.
May I have a look?
Okay.
Yes, I will.
Yes.
Okay. Do you notice anyone? Okay. Do you notice anything make this the rash is the worst, like stress or sun exposure or smoking or alcohol?
No, not of these really.
Do you notice anything improve with this your condition, like
Nothing.
stress or trauma or sun exposure?
Nothing really.
Is it painful?
Not really. But now it's becoming more painful. But
Mm-hmm.
at the beginning, it's not painful.
Mm-hmm. Where's the side? Just only in your leg, or there's other side?
Actually, when it started in my both forearms and now in my right foot.
Uh-huh.
Yes.
Okay. Is it oozy?
Yeah. It started to become oozing. There is like a something wound inside this rash. It oozed, doctor. Yes.
Okay. Is it itchy?
No, not itchy.
Mm-hmm. Do you notice any high body temperature?
No, doctor.
What about your weight?
Actually, doctor, my weight is decreasing, doctor.
Decreased.
Yeah.
Uh, how many over how long?
I think I lost around 6 kg over the last 4 months.
It was attended or not attended?
No, not intended. Although, doctor, I'm eating a lot, but I'm losing weight.
Any recently change into your diet or exercise?
No, doctor. I eat as usual. I eat a lot, doctor.
You mean your appetite increased?
Yeah. Always my appetite is like this.
Okay. Do you notice any excessive sweat?
No, not really, doctor.
Any neck swelling?
No, doctor.
Any lump or bump to the anywhere?
No, not really.
Any tiredness?
No, doctor.
Anyone comment you better than before?
No, doctor.
Any yellow discoloration to your eye?
Not really.
Okay. Any tummy pain?
No, doctor.
Any tummy distension?
No.
Any change to the bowel habit?
No, doctor.
Any blood passes from the back passage?
No, doctor, no.
What about your water work?
Actually, doctor, my water work is increasing, doctor, but now I think it's improved.
Increase the amount?
Yeah. I go to the bathroom every now and then, but when I went to my doctor, he like made a modification for my medication, and now I'm okay, doctor.
What's the medication?
I'm on
What's the
insulin, doctor.
Insulin.
Yeah.
Okay. Any change in the color in the water work?
No, now it's fine, completely fine.
Any frothy urine?
No, doctor,
Any joint pain?
not really. No.
Any cough?
No,
Any coughing of blood?
no,
Any chest pain?
no,
Any awareness of the heartbeat?
no.
Any medical history I should aware of?
Apart from my type 1 diabetes, I have
Mhm.
nothing.
Since how long?
And it's actually for 20 years, doctor.
What the last accumulated blood sugar?
Was 7.
What the medication are you taking?
Only insulin, and sometimes I take paracetamol for like if I had headache.
Are you compliant with medication?
Yes, I'm very compliant.
Are you a regular follow-up into the diabetic clinic?
Yeah, sure, doctor. But I don't like to go to the food clinic. Yeah.
Why?
I don't like the nurses there.
Okay. Any pins and needle sensation?
Actually, yes, doctor.
Since how long?
It's like for 1 year.
Where exactly the site?
In both feet and hands.
Any blurred vision?
No, I am following up with the eye clinic, with the kidney clinic. I'm all right. Yeah.
Okay. Mr. Omar, any history of previous surgery?
No,
Previous admission?
no,
Previous blood transfusion?
no,
Are you in long-term relationship?
no,
Any tattooing?
no,
Any share a needle?
no.
Any problem to the intimate relationship?
I had like a casual partners, but now, and I had no problem with them, and I had no problem, yes.
Okay. What are you do for living?
I'm a teacher.
How much does the symptom affect into the job and daily activity?
Really so much because it ooze and it turns to be painful now. Yeah, it affects me.
Okay, I'm sorry for that. I will refer to the occupational health worker to help you regarding the issue.
Thank you.
Okay. Any previous history, any medical history other than diabetes, like high blood pressure, high heart attack, high lipid?
No, doctor, no.
Okay, do you smoke?
No,
Do you drink alcohol?
no,
Okay. Do you drive?
no.
Okay, can I examine you?
Yes, please.
Regarding the ulcer, just only in your foot.
There is like on his right foot, this is the one that active, and in his both arm, there one, an older one, healed by scars.
Yes, and Uzi.
This one is oozing, yes.
What's the color of Uzi?
Like a cirrus, transparent.
Yes, is it flat or raised from skin?
It's like a plaque raised from the skin.
Okay, there's what yellow discoloration or just only all red?
Yes, in the middle, the whole plaque is red to brown, and there is in the middle, just in the middle, there is new forming ulcer. Regarding the rim, is the like purple color.
And in the middle?
And in the middle, there is a yellow, brown, red color, and there is also like a telangiectasia, and there is ulcer, new forming ulcer in the middle.
Yes, I want to examine the sensation.
Excellent. The sensation above it, you can say above above the black is decreased. And regarding the sensation in his both feet, decrease all four modality.
Mm-hmm.
Yes.
Okay. I want to examine the hand.
Other thing in the foot. You want to see in the foot?
Yes. Yes. Okay. The sensation. I want to check the pulse.
Excellent. Yes, the pulses are intact. All the pulses, dorsalis, pedis,
And stereotibial.
tibial, intact.
And sensation
Yes.
loss in both feet.
Yes.
There's no any ulcer in the sole.
Excellent. No ulcer and no like fungi or fungal infection between the toes. Good.
I want to examine the hand.
The hand, there is skip it. There is only the healed bilateral in the forearm, healed by scars. It's like the breast scars, like going down, like atrophied scars, something. Yes, it's disfiguring. Yes.
I want to examine the eye for pallor and jaundice.
Not pale or jaundice.
I want to examine the chest.
Normal.
I want to examine the S1 and S2.
Normal.
Cardiac.
Heart sound, no added murmur or sadness.
I want to examine the abdomen.
Normal. Anything you want to examine in the leg? In this
I want to
patient?
examine if there, yes, the pedal edema and the sensation is examined.
No pedal edema.
Is examined.
Anything in the other thing in the leg you want to see?
See sensory examination.
You did the sensation. Anything you want to see by inspection, or you want to feel for something?
No.
There is no dilated veins. There is no dilated veins. And we said no, there is no leg swelling and no scratch mark. And when you feel it, it is not hot.
Is not hot.
Okay.
Okay. I want to check the vital sign, blood pressure, sitting or standing.
Excellent. All vital signs, including the temperature, are normal.
I want to do fundoscopy.
Skip it. I think you did great. You did everything.
Yes. What's your concern?
Yeah, what's the problem, doctor? Why I'm getting this rash?
Yes, regarding your symptom. Well, regarding your symptom that you have, and after examination, I think you have a condition is called neurolipodica. This related uncontrolled high blood sugar. This can infection related to the underlying uncontrolled blood sugar. What we needed to do now, I needed to do reassess you to see if you need admission or not. And after that, run some blood tests and imaging to confirm our diagnosis. After that, if confirmed, I will refer you the diabetic doctor and diabetic clinic and occupation health worker and specialized nurse to provide to you the proper management plan.
Okay, doctor. Great.
Okay.
Yeah. I don't know about the time. I don't know. I cannot see the
1
time.
minute remaining. 1 minute.
1 minute remaining. Yes. Do you have anything you want to ask? Anything you want to answer? Still, you have 1 minute.
Any tanning of skin?
No, doctor. Thank you. Yes. Still you have one more.
Mm,
Doctor, are you gonna take like a snip from my time up? Okay.
yes, maybe needed
Okay,
to take
give
snips
her
from
this
the
concern.
lesion.
Yeah. Okay, answer this concern, then we'll go the examiner time.
Doctor, are you going to take a snip from my
Yes,
rash?
maybe needed to take into the snip from your skin to confirm our diagnosis.
Okay, thank you, doctor.
Mm-hmm.
So examiner question.
Uh-huh.
Okay, give me your finding on examination.
Yes, regarding this patient, known case of yes, is presented the skin lesion in the both feet is raised erythema patch with the yellow discoloration at the central. The sensory examination lost, and both the pulse, dorsalis pedis, and posterior tibial was normal.
Okay, so what's your give me 3 differential.
Most likely maybe a neurolipotica, and also maybe a neuropathic ulcer based on the patient lost the sensation in both feet. And the third differential diagnosis may be venous ulcer.
Excellent. Okay, so how you are going to investigate?
Apart from the basic investigation, CBC, LFT, inflammatory marker, and blood sugar, hemoglobin A1C. I want to do I think I want to do the brachial index, and also I want to do the X-ray to see if the joint affected or not. And also I want to take the snip from the lesion.
Okay, when you take a snip, you want to differentiate it from what?
Maybe from the neuropathic or arterial ulcer, but I am not sure.
Okay, so
but again, differentiation between according to the site.
Okay. Then how you are going to treat?
The first of all, pharmacological and non-pharmacological, patient education, patient counseling. I want to control the blood sugar by refer patient to the diabetic clinic, and refer to the patient to the food clinic. And also I want to control the blood sugar. And also I think treated with the ulcer, if the venous ulcer, by the bandage and elevated the leg. I don't know, but I don't know exactly the treatment. Maybe steroid.
Okay. So do you think this patient has a trauma before getting this kind of rash?
Yes, maybe patient trauma and maybe cellulitis, someone with differential diagnosis, or
insect bite, or
insect bite. Yeah. Yes, or insect bite. Yes, I didn't ask the patient about that. Yes,
or like a Kupffer phenomena. Am I right?
Yes. But Kupffer phenomena, not lesion, is not like this.
I mean like this
after trauma. You mean after trauma?
I mean after trauma. I actually have no other question. Dr. Basil.
How to manage? Yeah, how to manage?
Okay, so tell us more how to manage.
Control the blood sugar. First of all, control the blood sugar.
And first of all, multidisciplinary team.
Yes.
First of all, multidisciplinary. Yeah, then go ahead.
Yes, yes, patient education, patient counseling, psychological and social support, support, refer the patient to the group special multidisciplinary team, include the diabetic or nerve doctor, specialized nurse, and occupational health worker. The second treatment, I think, second, control the blood sugar is the most important. The third, I think treated with the steroid.
Is there any, if the steroid is not effective, or what other you can use?
I think immunosuppression like tablet tacrolimus.
Okay, apart from the tacrolimus, if it doesn't work.
Other immunosuppression.
Like?
Like cyclosporine.
Like the TNF inhibitor. صح? TNF inhibitor. Okay. لا. Okay. So time up. Okay.
Yeah, time is up. Yeah, please welcome. Well done, Dr. Rasha. And we'll receive the comments from Dr. Hoda first, then I will comment.
You did great. It's necrobiosis lipoidica. Regarding like your analysis for the rash, you ask almost everything, but you have to ask how did it start? Like started as a small papule, started as a pully, started as what? It in necrobiosis start as a small papule, and it get increase in size. And you have to ask if it is preceded by a kind of trauma or not, because it in some cases it can show a Kupffer phenomena. And you have to ask her, this ulcer, when happened, is it preceded by trauma? Because sometimes a trauma inside the rash itself can lead to ulceration, and the patient has no sensation at all, so he might not remember even the trauma. Regarding, but apart from this, you ask from everything, and the examination is complete. I have no comment. Regarding the investigation, it's a clinical diagnosis, but you need to take a biopsy, although like it is challenging, because when it showed Kupffer phenomena, so it will worsen the condition, but you need to take it to differentiate it from, for example, sarcoidosis, granuloma annularia, and that's it. And your differential also is good, like a varicose ulcer, neuropathic ulcer, yes, especially if there is ulcer. But if there is no ulcer, you can say sarcoidosis, you can say granuloma annularia. I think so. And then you will check hemoglobin A1C, and yes. Regarding the treatment, in some area they wrote like controlling the blood sugar has no relation to the improvement or not, and in some areas they said it might affect. And if it is only like a rash, there is no ulcer, you will leave it heal by itself. But if there is ulcer, you will need to give a patient a steroid. If not effective, as you say, topical tacrolimus. If not, you will give TNF alpha inhibitor. And yes, you did great. Thank you.
Yeah, thanks, Dr. Ruda, for a new dermatological case. We always practice a different system, but today we have dermatological case, which is somehow it's different for us as a presentation. Anyway, it might come also as a complication of diabetes. And great by Dr. Rasha to discover the diagnosis. Actually, it's difficult case. So let's comment about the performance. Dr. Rasha did great, starting from the onset course, duration, the site, the previous attack, where it was started, any other area in the body, and the analysis itself about the rash, the oozing, the itching, the feeling, the oozing and itching, yes, and feeling around or above it was all great questions. Then analysis of other systems, CNS, just quick review, it was great. And when you reach to the genitourinary, you found that This patient might have diabetes by the frequency of the urine and frothiness. Immediately you can ask about the feeling thirsty. Just be sure that he is diabetic patient. And you can ask for the complication of diabetes at the same time. Retinopathy, you ask by the CNS, nephropathy in GI, and neuropathy in the leg, again in the CNS, pins and needles. You ask all these questions even in the system review, a separate system review, not in the diabetic, I mean in the diabetic category. You ask in the system review, system by system. The constitutional symptoms, great to ask to rule out any cancer lesion. Temperature, weight, appetite was increased due to diabetes, sweating, lumps or bumps, tiredness. You did all these questions. The joint, I'm not sure if you ask about the joint, but it's okay, nothing here affected. Then the social family history, travel, medical history, and it was rich of information. Patient is diabetic type 1 since 20 years. His hemoglobin A1C you ask about, it was 7. So great question. And the clinic, I like the question for follow-up clinic. Are you following why he told you, no, I don't like the diabetic or the foot clinic? Why? Because of the nurses. You can address more and you can immediately tell him, we can help you in this regards. Why? Because he will have advice for this in the future. He should do all this clinic follow-up, the ophthalmology, diabetic foot, and neuropathy. He should follow all of these, as well as the major vessels. I mean, you ask also for the central stroke, I mean, CDA, previous CDA, any stroke or mini stroke, this great question. And another question for heart attack or high blood lipid. Actually, Dr. Asha, you did very well. The HIV, you asked for the intimacy. It was a great question, but you didn't ask about when he told you, I don't have partner. So do you have any casual relationship? She said yes. So analyze more. Was it protected or no? Is it important, this patient? What do you think, Dr. Hashim? If the patient is HIV, do you think he might be HIV from
Yes.
casual
Yes.
relationships? Yeah,
Yes. Is it important?
immediately. Yeah. So you found that the patient having casual relationship immediately. Do you have unprotected sex or you are practicing protected sex or no? He will tell you, and accordingly you can put, because any HIV patient might have any skin lesion as a differential. You can put HIV if the patient is HIV. So when good question you ask about this and you didn't analyze it, so make more logic to ask about the HIV risk. Okay, the job, the smoking, the alcohol, the driving is not related at all. You don't need to ask unless he is not feeling and his pins and needs or neuropathy is affecting him. And in this patient, yeah, you might ask if he can feel well at the driving while driving or no, so to rule out and to be safe with the patient. This is for the history. For the examination, you did great. You did the full examination of the rash by the look, by the feeling, by the ulcer, and the sensation around, the pulse around, the fungal, and yeah, the pulse everywhere in the legs because it might be vasculopathy. Abdomen and vital, you ask. The fundoscopy offer good for retinopathy, great as well. So our differential in this patient, necrobiosis lipotica, you can put also granuloma annular as a diabetic patient, venous ulcer, neuropathic ulcer, or arterial ulcers. All these can be put. And I don't know, leprosy can be here, Dr. Roda, because patient has no sensation around. Leprosy as loss of
Really, I don't
sensation.
know, but is the logic,
Yeah,
yes, I think so.
yeah,
I don't know.
yeah, yeah. If no sensation, we can put it. Anyway, we have a lot of differential, but the specific lesion in the exam, I am sure maybe 50 or 70% You can't remember the name of necrobiosis lipoidica, granuloma annular. I guess we can, if I am not remembering the name, I can correlate it with diabetes. I will say diabetic, uncontrolled diabetic related rash. I will say that because if I put a wrong name or if I give a wrong name, he might deduct my mark. I'm not dermatologist, by the way. Most of us also, they are not dermatologists and they might not reach to the name of the disease. So if you forget, you can just say diabetic related or uncontrolled diabetic related skin rash. He will not blame you. Why you didn't know the name? Because I'm not dermatologist. I'm not familiar with this disease. The same as the management, Dr. Rasha. You are trying to give steroid in patient with diabetes, blood sugar will be uncontrolled. So the best answer ever in any patient with something, let's say it's not your specialized or not your specialist, and you are not specialized in this disease. How you would manage this patient? You will give steroid? I'm not sure. So what I will say, multidisciplinary team approach, first word in this patient, and the dermatology will be in the top of my team, plus the dermatologist and specialized nerves, tissue viability nerves. I consider vascular team. So a lot of team, but I'm not the one managing because I don't know what to give. I will tell the examiner, I will give steroid, it might be wrong and it might affect my mark. So the best answer ever, refer to the dermatologist. Even I know the answer. I don't know. For me, I don't know that I will give tacrolimus topical. I just now know from Dr. Roda, tacrolimus topical, TNF. Okay, but I am not sure about this. If I say this medication by myself, it's unsafe. The examiner will give me minus because this is not my specialist at all. I will not manage this patient by myself. By the way, I internal medicine. This exam for internal medicine, not for dermatology. So the best answer, don't mention any pharmacological. Start by our systematic answer. Multidisciplinary team approach starting from dermatology on the top, then diabetology, vascular team, even neurology team for the neuropathy, and endocrinologist, then the specialized nurse who are like tissue viability, foot care nurse, and social worker and GP and etc. Then non-pharmacological patient education and counseling about disease complication, how to prevent and to avoid venous ulcer, to avoid and to prevent the arterial ulcer, the same for neuropathic ulcer, how to use the shoes for diabetes, how to control his diabetes. I can take long for this. Then I will go to the pharmacological. Once I reach to the pharmacological, after I confirm the diagnosis, I will manage this patient. I don't know the diagnosis yet. It's a matter of dermatology diagnosis. Maybe he will take skin biopsy. Maybe he will do fluoroscopy. Maybe he will do some procedure which I don't know. I'm not familiar with this patient diagnosis. Cobb might be there. I'm not sure. So for I will do what I will do myself. I will just tell him after opinion from dermatology and according to the finding of the biopsy or skin biopsy, and I will manage this patient. If he asks you further what you know about the medication, you can say what I know, because never he knows the management of this patient, the examiner himself even, because this is pure the dermatological case. Even the diabetology might know about the complication, but they don't know how to manage. Any patient with diabetology or diabetic skin lesion, they will refer him to the dermatology. Anyone working in a specialized hospital, no one is managing the skin rash, even for the contact rash, for the diaper rash. No one is treating this rash by himself. He is referring to the dermatology and waiting for the advice from the dermatology. Even I know the diagnosis. So better to be safe, not to mention the pharmacological, unless the examiner asks me more to these details. And maybe, sure, if he reached to this level of exam question, he want to give me full mark. But also to be safe, I should mention this the team concerned to this rash. Okay, thanks for nice two cases today, Dr. Rasha and Dr. Rhoda. Let's take the comment, complication, necrosis lipidica, disfiguring, squamous cell cancer, sepsis, ulcer, pain. We need to take swab if sign of infection. Dr. Rhoda, yes. Syphilis, yes. That's why it's important to take sexual history. Any skin lesion might be related to risky habits. Sarcoidosis also differential as, yeah, but no cough history and no hypercalcemia history. But still, you mean erythema nodosum, myoderma gangrenosum? This is what we know, all of us. This both common to rash in the medicine. Erythema nodosum and myoderma gangrenosum related to inflammatory bowel disease and sarcoidosis. But again, while you reach to the management, don't give medication by yourself. Okay, Dr. Rasha, please try to involve the team. And after the team advice, I will give. After the snip or the biopsy result, I will give. But I will not give medication according to just by look. Okay, and steroid might harm this patient. Steroid as systemic, I mean, might be topical steroid. I'm not sure about this management for this disease. So don't decide for steroid by yourself. Try to refer to the concerned team and wait for the advice. Then they will go tell you the advice for this indication or for this disease management. Thanks, Dr. Rasha, Dr. Rhoda. If no more comments,
Yes,
we can, yes,
yes,
you have comment
nice
or
case.
question?
Mhm.
Yeah, a long time we didn't practice dermatology or skin rash cases. Okay, thanks also for your case, Dr. Rasha. It was nice case for differential. And it's common scenario in any transplanted patient, either to have tremors, to have the rejection, to have infection. Transplanted cases might come as short in the kidney itself, as in the abdomen itself. It might come as long consultation as well, long clinical consultation. So it's common case, and it was good differential and good case to do. Well done, Dr. Yes. Thanks all. Let's go to the communication.
Yes. Please,
Okay.
دكتورة تانية لو تجيب give me the case.
Okay. Dr. Tanya.
Yes,
Yeah.
I will
Okay.
give.
Great. You are here. Alhamdulillah. Okay. So start together, please. Yes, Dr. Tanya was the case for you. Can you read that loudly, Dr. Sarah?
Okay, here. Where is the case? Okay. Miss Mary, 35 years old, presented with generally SID, tonic-clonic convulsion, يعني ايه SID. Also, she reported sleepwalking. CT showed temporal lobe lesion and neurosurgeon suspected MS. Plan for MRI, explain CT result and the plan of MRI. Okay. بس يعني ايه SID؟
Which word, Dr. Rasha? Dr. Sarah? Said
SID.
generally said maybe
No, this is maybe this just spelling mistake.
Oh, okay.
yeah, said.
Okay, okay.
So
Just
the
a couple
case
more
in front.
minutes. Okay.
Yeah. All can
Okay.
see the case in the screen.
Yes, it is there.
Yeah, okay. So 2 minutes, Dr. Sarah, then we'll start. So Sarah, when you're ready, let me know.
Okay. Um, um, Miss Mary. Okay. Hello. I'm Dr. Ghanem, doctor in clinic today. Am I talking to Miss Mary, 35 years old?
Yes, doctor, Miss Mary.
Hello, Miss Mary. Um, we are here to discuss some issue related to your health condition. Is it okay with you?
Yes, it is okay.
Okay, before we start, if you need anyone to attend this meeting with us, it's okay.
Yeah, it's okay. I don't want it.
Okay. During our conversation, if you need to ask any question, don't hesitate to stop me and ask, okay?
Okay.
Now, can you tell me how much do you know about your condition?
Yes, doctor. For last few months, I had several attacks of like shaking of my body parts, and also I was like my husband partner is telling that I'm walking during sleeping. So I went to my GP and they transferred me here. They did some scanning, I mean, some image of my brain. So I'm so afraid. I don't know what happened actually.
Oh, thanks, Miss Mary, for sharing information with me. I have now the result of your scanning. I'm so sorry, it is not as we hope.
But doctor, why? Am I having cancer?
I'm so sorry. I'm so sorry to tell you that we found like a lesion in your brain, um, and this lesion suspected to be a disease called multiple sclerosis. Do you know anything about it?
No, doctor, what is this?
Um, okay, multiple sclerosis is a disease affecting your nerve cable, nerve cables that connect the brain with your body. This lead to some lesions and some symptoms like you experience it, which are convulsion or weakness or sleepwalking or sometimes numbness, weakness in limbs and other symptoms. I'm so sorry for that.
Oh my goodness. So is it dangerous, doctor?
I'm so sorry to tell you, yes, this is a dangerous, a serious disease, serious condition that can lead eventually to loss of mobility.
So you are telling that I cannot walk?
Um,
Future?
I want to explain you something about this disease. This disease come in attacks like come and go. Some people may have some attacks and go into remission. I mean, the disease stop like this, and some people may have more progressive disease, which may affect other nerves in their body, and eventually lead to they cannot walk. This is not expectable. It is it differ from person to another. Are you
Okay.
following me?
Yes, yes, yes. So you told me that I will lose my mobility.
This
So
could
it
be
is.
happen. This could happen. This is not true, but it could happen. Some patients experience this.
So there is no medication, doctor? Give me medicines.
I, I, I have to tell you that there is no cure for this disease, but there are medications that can help patients in improving symptoms and dealing with these symptoms.
Oh my God.
I'm so sorry for this feeling, Miss Mary. Miss Mary, how are you feeling now? Can
Yes,
I help you?
doctor.
Can I give you a glass of water?
Yeah, please. I need that.
Okay. I appreciate your feeling, Miss Mary. I know this is maybe a shock for you, but I am telling you that we all here to help you, and we can support you as ever, as much as we can. Um, I appreciate your feeling. I'm so sorry for your feeling.
It's okay, doctor. It's my fate.
Okay, Miss Mary. Now I can tell you that we will do plan of management for you to help you to pass this situation. Okay.
Yeah, please, doctor.
Okay, but before I start telling you about our plan of management, can I ask you some questions?
Yes, yes, doctor.
Okay. What do you do for a living, Miss Mary?
Oh, I'm a banker.
Okay, is this symptoms affecting your job?
Yes, whenever I'm having this attack. Last time it also happened when I was working.
Okay, I'm so sorry for that. I we will let our occupational health services to deal with this, and I will give you a sick leave. Okay?
Okay, okay, thank you. Much appreciated.
Okay. Um. Um. Okay. Do you smoke?
Yes, doctor. I do smoke.
I have to tell you that smoking is a bad habit, and this can affect your health. Um, would you think that you can stop smoking?
Okay, doctor, I will think about that.
Okay, I will. I advise you by with the smoking cessation clinic that could help you with this regard. Okay.
Okay, thank you.
Do you drive?
Yes, doctor, I do drive.
Now you have to stop driving right now because of these symptoms that may be very dangerous for you and for others. It's okay?
Okay, doctor.
Okay. Any hobbies? Do you have any hobbies?
For me, hobbies, yes, I love swimming.
Oh, okay. Swimming, you need to be watched and not swimming alone because of these symptoms that could happen to you when you are alone, and this is dangerous for you. Is it okay?
Yeah, doctor, what to do?
Okay, that's great. May I ask you, could you do you have a partner?
Yes, I have.
Could you be pregnant by any way?
I have plan actually for next year, but I don't know now.
Now we have to postpone this, okay, until we do our investigation and plan of management. Then we can call a woman doctor to plan with you. Okay.
Okay, doctor.
Okay. Now we will talk about our plan of management. First, we have to do some investigation for you, um, as scanning for your brain.
Okay.
To know to be sure about the diagnosis and to make a good plan for management. Okay.
Okay.
Then we have a multidisciplinary team for a group of specialists that could help you in our plan of management, like the nerve doctor and the social worker and occupational worker.
Mhm.
They could make the plan of management for you, okay?
Okay, doctor. Okay.
Miss Mary, do you have any other concern?
No, doctor. No. One concern only that if my baby is having this also, if I'm getting pregnant, my baby will get that.
Miss Mary, I'm not sure. Maybe you can ask a genetic doctor about that, and I will tell you. Okay?
Okay. Okay, doctor.
Okay, but if you get pregnant, we need to control your symptom first before starting to plan for pregnancy. Okay?
Okay. Okay, doctor.
Also at home, there a lot of some lifestyle modification to do. Just like not taking bath alone, not lock the door from inside. Are you follow me?
Yes, 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 doctor. I'm following you.
Yeah, time is up.
Okay.
Okay. Yes.
Yeah, you want Dr. Tanya, please? Well done,
Yeah.
Dr. Sarah, by the way.
Yes, Dr. Sarah, you
Thank
did
you.
very great, because it was with so many hidden agendas, so many that it is really difficult to tackle within 10 minutes, I feel. But almost everything you covered, Alhamdulillah. So you really did excellent. Just a few things that just it came to my mind when you started. Uh, like some jargons you used actually, like convulsion, numbness, nerve, investigation. So not convulsion, you can use like fits. A numbness better, I think, if you are telling sensation loss or low sensation, low sense. Nerve, the cables of sensation. Investigation, test. Better to use the word test and not scan, like the image, brain image or anything. So the jargons actually came in between. Other than that, this was okay. And actually, here obviously there was fits. So the fits related. Okay, somebody is telling numbness is not a jargon, so I'm not sure about this one. Okay, then it is not a jargon. Okay, and
Okay.
then actually there was two things here in the case, like breaking the bad news of MS, that I'm having MS, and the second one is that the plan for MRI. Second task, you told me that we will do one investigation, but you didn't utter that. You didn't utter that you were going to do another image of my brain that is known as MRI, that is the magnetic resonance image, because this is actually one of the tasks. So better to mention this even in one sentence, that this is same like the image test, like it is non-invasive, and we will use that magnetic and some waves to take the image more clear for your brain, so that we can go for further plan of management. So this is the thing I think it was missed, that mentioning of MRI, because it was in the task actually. And you did very well with all that fits related safety netting, you did very well. And just one thing, that when plan of management, you didn't mention which doctors or who will be in the team. Mentioning of a team, that there will be brain doctor, specialist nurse, and mood doctor, social worker. So just this mentioning of this specialized team. But actually it was so huge and so many tasks inside, so I feel like nobody can do better than this. You did really great. Thank you.
Thank you, Dr. Tanya.
Yeah, I agree with Dr. Tanya. Dr. Sarah discovered a lot of hidden things in this scenario, and she did it. For
Yes.
pregnancy, for example, she asked for pregnancy, which is difficult to remember in this scenario. But let's start from the beginning. Dr. Sarah, you did great, starting from the introduction, invitation, the knowledge about the disease, but the expectation, again, you are forgetting the expectation. I don't know why. You
Oh,
can
yes.
take, the expectation from the patient will give you a hint what to talk about. Might she knows about this disease? Might she thinking something serious? And by this, it will prepare the patient well to the hard or shocking news. If she suspect, like the cancer, so it's serious infection or serious disease, it's near to the cancer. So it's just absorbing this shocking news by preparing her by expectation. The results are with me now. It's not as we hope, yes, and the golden silence, you did it, and you can give her a certain second, just a few seconds to absorb and to then to ask her, are you okay now? Do you need a glass of water? However, you did it later, but it's okay. You can do it while the shocking news is the first. Then you explain well about the disease, but you mentioned convulsion, which is jargon, yes. Abnormal movement in the body, nerve cables, disease at its a defense. It's a disease of defense system attacking your body instead of attacking the bugs. And this organ or this areas attacked by the defense system, they are the brain itself and the nerve cables in the back, and the manifestation will be as you practice. The abnormal movement, the abnormal feeling, the pins and needles or numbness, it's okay, both of them are okay. Pins and needles, feeling, sensation, the change, and abnormal movement. The concern of the dangerous, yeah, it's dangerous, you're right. But before letting her giving concern, it's still undiagnosed, Dr. Sarah. My advice, stick to the plan of the task. Your task is uncertainty of the diagnosis. Suspected MS. So you cannot tell her this is MS. We suspect a lesion and suspect a disease called 123. So what we'll do, we have to do another image called magnetic resonant image. It's a field of magnetic area that it will show us more about your disease and it will confirm your disease. If she asks you, doctor, please let me know more about the complication. Is it dangerous? Yes, it's dangerous. It might up to the level of immobility. It's great to mention it, but start by the simple, then the dangers. So what to start the simple is some feeling problem, some difficulty of walking, as you mentioned. At the end, it might reach to immobility. I'm so sorry, and I'm afraid to say that you might be unable to walk or disabled, and you might be bound to wheelchair. Are you serious, doctor? I am so sorry, and I'm afraid to say yes. This is one of the complications, and I'm sorry to be the one deliver this information to you. I know it's shocking to you, and you can support another. Yeah, you can ask for support again if you need something to drink or tissue. However, don't worry, we are here with you. We will support you all this journey. We will give you the maximum support you need in your life. Our team are professional and expert in your disease, and they will follow up you. They will manage everything. And don't forget the eye. Sorry, I didn't mention the eye in the complication. Eye vision might be affected. That's why you might be unable to drive. It will come later. The second concern, medication. Yes, there is medication according to the type. Don't give one type. We don't know what is the type. Maybe relapsing, maybe primary progressive, maybe secondary progressive. We don't know what is the type there. But the good thing you said, it's coming and going. It comes and goes in attacks. This is the commonest type. But don't give this type. Maybe it will be primary progressive, starting mild, then progressive immediately, and the patient will be unable from the start. So according to the type, we will decide. Yeah, you mentioned differ from patient to patient. It's nice. Yeah, it might be different from you, from other to other. So it's one of the accepted answer. Medication answer, yes. No cure, yes. No cure for the disease. However, our doctors will try to do the best just to give you near normal life. However, it's not curable disease. Yeah, we will try our best to reduce the complication and the frequency of attacks. Comes in attacks. So we will try to make the attacks far away from each others. Okay, yeah, you talk about the MRI, but it should be earlier. I wrote it here late because you mentioned it late. So it's uncertainty. You should mention the MRI before explaining the disease. Then you explain the MS. Okay, the kids concern, the kids. I'm sorry to say, or I'm afraid to say, it's not familiar disease. However, your kids might have possibility to get the disease more than other normal people. Okay, it's not familiar one, but your kids might have the disease. It's not as familiar or genetic, but it's like multifactorial. It's related to the family, or it's like that compared to the other persons or the intact or a normal person. The job you address, the smoking, the alcohol, the driving, very important here you did, but I'll ask her to inform Devil. It's not your task. Hobby, I like when you ask for the hobby. I never think about hobby, but you did it. The pregnancy as well, you did it. You might have a planned pregnancy with your woman doctor to control the disease first, to have a safe baby and safe pregnancy. Multidisciplinary team, as you mentioned, approach will be the one following you and managing you. Yeah, in general, Dr. Sarah, you did great. Every day you are doing much better than the previous practice. I believe that you are going in the good and perfect way. I hope you
Thank
practice more and more. Yeah, you will be more professional.
you.
Yeah, and the point is you are not quiet. You are not before you have some pauses while asking. You don't have the answer. Now you are having the answer, immediate answer. You are fluent with the questions. This was before there is some delay, or there was some delay in the answer, but now you are answering perfect way and rapid answer. So let's have the comments from others. Investigation commonly used in UK, daily practice, yes, it's okay. Brain scan is not a jargon, yes. Numbers is not a jargon, yes. If we are not sure of the diagnosis, we could break the news for the patient. Yes, because it's suspected one. The MRI just to give the confirmatory test. But what's written here is neurosurgeon suspected MS, and the disease is still finding going with MS. Young female with tonic-clonic convulsion, sleep, sleep walking, difficult walking. Okay. So you will talk about the MS, but after confirming test, which is MRI. Because what's the task here? What do you think? You will talk about MRI only 10 minutes? What about MS? You will not give any hint about MS? No, it's your task. Possibility, but to confirm, we have the MRI. That's it. The MS explanation as breaking bad news, and the MRI as a task, and complication, and some support, and so on. Yeah, the good question also, Dr. Sarah, you mentioned the partner, but when you mentioned the partner, I thought you will talk about the support, anyone in the home supporting you. So better also to ask for the support, anyone supporting you at home, because this patient, as you said, sorry? Yeah, you mentioned as the patient is this will be disabled, so the family will support her in the future. Yes, Dr. Hind, you have any comments?
Actually, I
Yes,
want to add some major changes in the scenario.
yes, please go ahead.
طيب أولاً what is the title of this scenario? If we will give it a title حتى نقدر نعرف بعدين شو التغييرات بدنا نغيرها. If you had such a scenario in the exam, the best title is counseling about first seizure. Okay? And not the cause of the first seizure is not yet known. But there is a lot of stuff to mention about whenever you are counseling a patient after his first seizure. If there is recurrence or not, what lifestyle changes he need to adopt, what were the triggers, okay? So all those things gonna consume your time. And you have just to mention simply that because of some changes in your brain, we are suspecting a cause which could be MS. Something else. Who put this scenario? Dr. Tanya, right?
Yes.
Dear Dr. Tanya, from where you get this scenario?
Some group they have posted. I just copied and pasted.
Okay. But يعني, I would argue against the possibility of seizure in MS. Have you ever read about seizure as manifestation of MS? Usually in
listed in
MS,
this.
it's a demyelinating disease and it
Yeah.
affects the white matter. And seizure is abnormal electricity transmitted in the for sure in the cortex. Nothing have to be done in the white matter and demyelination. Usually seizure is a very rare manifestation of MS. Mainly MS is focal neurological symptom. We usually have balance, even in the LCC. In the LCC, whenever we have a collapse, and then the cause of the collapse is seizure, we discuss everything except MS. We don't mention that MS is a cause for seizure usually. So that's why I feel there is something about this scenario. But anyway, let's suppose it is like this, came in the exam. So it's a counseling about first seizure, but because of a presence of some kind of abnormality, we are thinking about, or we are suspecting a kind of a disease called multiple sclerosis, which need further confirmation, okay? The MRI usually is done for epilepsy, because if you want to find any abnormality, structural abnormality, and it can be done for the MS, okay? So it can be for both. Either it will give me, either it will give me a confirmation about, is there any echo? Either it will give me a confirmation about the epilepsy and any structural abnormality or MS. If I talked about a susceptible, suspected diagnosis, in general, never ever go deep. Never ever go deep, because it don't make sense to explain everything about this, a disease, which I might tell the patient after in his second visit that he don't have it. So only in case the patient asks, what are the, if it is a concern, what are the complications if it is MS? At that time, I will answer him, okay, if it is MS, then the complications are 1, 2, 3. طيب, what if the patient asks me about the complication in general? I will talk about the complication of seizure, that it might happen again, okay? It might cause for you some injuries, okay? Like whenever you had any seizure, you sustain fracture, bruises, kind of injury. It might affect your lungs, aspiration pneumonia. I will not talk about the complication of MS, except if he asks specifically, okay? Such a case is very tricky. Let's forget about the MS. They can suspect a tumor, they can suspect whatever. I will talk about the suspicion in the beginning, then I will forget about it because it still needs a confirmation, and there will be a lot of further follow-up meetings to talk about the disease in case we were able to confirm it. And I will talk about the first, I will consider the scenario as a first counseling for first seizure, because there is a lot of items, hobbies, support, lifestyle changes, triggers, driving, a lot of things to be discussed regarding the first seizure. And here the patient will start talking about epilepsy. So you will tell him this is the first episode, so we cannot call it epilepsy yet. We need some further evidences, like either recurrence of the abnormal movement, or evidence on the MRI, or evidence in another brain tracing study, okay? or some other further evidences we might obtain them in the follow-up meetings. Then, if those things fulfilled, then we can call this epilepsy. طب will you treat me, doctor? No. No treatment at this stage. It's the first seizure, and MS is still a suspicion. So I will tell him for now, it's the first seizure, and we usually don't start treatment except we have an evidence, okay, for the cause of the seizure. Or if it happen again, usually we start the medication after the second episode of abnormal movement, okay? So there will be no treatment at this point, but the important thing to be done is to implement the lifestyle changes, to be careful not to have any high-risk hobbies, not to drive, okay, to be safe in most of the situation. In case the seizure happen again, you will not sustain an injury. That's it. And we will keep you under monitoring, and we will do some further investigation. So at any scenario where there is still a suspicion equal, you are still in the workup phase. Okay? You are not yet in the treatment phase, except if there are some symptomatic treatment until you confirm your diagnosis. But never ever talk about treatment of any disease, and it is mentioned clearly it's still in the suspicion, because this means you are talking about a scenario where you are still in the workup phase, in the investigation phase, not yet in the management. So you will not speak about the management because there is still a lot to be done as a workup, and lifestyle changes and advices, avoidance of triggers, support. We will take care of those things first, then later on, after we confirm the diagnosis, we can speak about the management phase. Okay? So always the scenarios of suspected diagnosis, they are very tricky, because you should never agree with the patient, especially in cancer cases, even in such cases. You should never agree with the patient if he tell you, doctor, what is the outcome or this stuff. Never ever give any definite answer. Tell him we are still not, we are not yet sure of the, and also acknowledge the feeling of the patient. I can see that you are stressed and you wish to know what is your problem, and we will try to do our best to achieve the diagnosis as soon as possible. But for the time being, it's difficult to answer or to comment because we did not confirm the diagnosis yet. Okay, I will be able to provide you with better answers after confirming the diagnosis. So always try to escape whenever the patient asks about something which we cannot answer it except we have a definite diagnosis. I don't know the outcome and I still have just a suspicion. I don't know the management and I'm still having a suspicion. Okay? So this is what I wanted to say, and I'm really sorry because I changed everything.
No,
Dr.
no.
Hind,
Thanks, Dr. Hind.
please,
Yes,
can I
Dr. Saad.
comment? Okay.
Yes,
When
sure,
I see
sure.
when I see this scenario, I thought that he want us to talk about multiple sclerosis. If he want us to talk about convulsion or fit, could it be epilepsy only?
لا dear,
why
لا.
he mentioned
See, the scenarios in the exam are not 1 + 1 = 2.
okay,
If
what
I
is it?
want you to talk about epilepsy and I will write from you patient who came with the, usually they confuse you. First of all, you have to know the themes of the scenarios. Whenever there is a case of convulsion, there is a variety of scenarios which are tricky about convulsion. They will never bring for you a case of even epilepsy is there, but they sometimes play on the first seizure, and it is there in rider. There is 2 scenarios, either first seizure or epilepsy. It's not that I will bring for you epilepsy, yalla, straightforward. Go for epilepsy, give him anti-epileptic drugs, and that's it. Here, the scenario, usually they love such a tricky scenario where they give you a suspected diagnosis and a presentation, and they will see which one will drag you. Is it the suspected diagnosis or the confirmed situation? The confirmed situation is a tonic-clonic seizure. So I will talk about this. I will give advices about this. And the suspected MS, later on, either we will exclude it. Imagine now you spend the scenario about MS 10 minutes. And in the second visit, you just simply told the patient, oh, I'm sorry, you don't have MS. We wasted previous visit talking about a diagnosis which you don't have. I scared you. I mentioned for you a management plan. And all of those things are useless. Nobody gonna do this. I will never talk about a diagnosis in detail, and it is not confirmed yet. At least this fact I'm sure about. Okay? So يعني from all what we have discussed, MS is not the essence of this case. Okay?
Yeah, clear now. Makes sense actually, Dr. Hind. Yeah, either to be confirmed or to be uncertain, but still no need to talk about the disease until to be confirmed.
Until it is
Yes,
confirmed.
I agree with you,
I will
Dr.
not
Yes,
counsel a patient full session
yes.
about something which might not be there.
Yeah,
Scare
you're
him
right.
with the
Yeah,
complication and stuff.
absolutely
Okay?
right. Yes. Psychic trauma he will have without benefit. Yes, I'm agree with you. Yes. Yeah, Dr. Muhammad. Yes.
Yes, I just want to add something about this scenario. Actually, I have an idea about this scenario. It came last night in Oman.
Yes, please. Yeah,
The scenario
clarify.
was not like this. Actually, the scenario was a lady. She had a history of déjà vu, and she got first attack of seizure while she was doing shopping with her husband. And they took her to the ER. They did a CT. They found that she has a right side mass in her brain. And they consult a neurosurgeon. And he advised to do an MRI to confirm the diagnosis. This was the scenario. Came last night in Oman.
So there was no
Totally
no
changed.
MS.
Yeah,
It was a
no
space
MS in that.
occupying
No.
lesion.
Yeah.
Yeah, I
There
agree.
was there was a mass in the CT, and the neurosurgeon opinion was to do an MRI to confirm and to know what this mass exactly.
Yes. Yeah.
And you need to explain the déjà vu for the patient, and you need to explain the seizure and issue like this. But there was no MS in this scenario.
Yeah. So makes sense if like this. So Dr. Tanya, let's repeat the scenario in another way in the next session to be more in the correct way, I mean.
It makes
Yeah.
sense.
Yeah. Thanks, Dr. Hinda, for correcting us. And I'm so sorry for this misunderstand. I'm so sorry, Dr. Sarah, as well, to do this case in in
Yeah,
The
I'm
trick is
proper
sorry
way
that I
because of
copied
this.
sometimes
No,
this.
it's okay.
sometimes do you know يعني it is something of benefit because
Yeah.
you
The
will
debate
learn
always.
things
Yes.
in the most
Yes.
difficult way because we don't know
Yes.
يعني we don't have knowledge of everything. But if I have the general headlines, like in
Yes.
any scenario, what I should talk about and what I should not talk about, what I should focus on and what I should just spend 1 minute about. So even if we forget about the how correct is this scenario and or what are the mistakes, at least the approach should be fixed. If I remove seizure and I put, for example, weakness, and the patient had weakness and they found some lesion suspicious of MS. Again, I will not talk about MS in all its full-blown picture. I will just prepare the patient, tell her what I will do, that I need to have another attack, could be vision, because usually MS need dissemination in time and dissemination in space. And actually this scenario is there. The one I'm talking now, that it's weakness, first attack of weakness, they are suspecting MS, still to be confirmed. So you will speak about the criteria to confirm MS, and that you will do the MRI, and if you find something abnormal, it will be confirmed. And again, you will go to the social, lifestyle, triggers, support, and those stuff. So this theme of uncertainty or suspected diagnosis is very important and very confusing. And they love it, actually. Nothing is straightforward when they bring those scenarios. Don't expect like disease counseling. Those scenarios are very rare now. Like you have a patient with this disease, counsel him about Crohn's, counsel him about SLE. Those scenarios are not like common like before. They love to twist things nowadays. Okay?
Yeah. Thanks, Dr. Hind, again for the correction. And thank you, Dr. Muhammad, as well for clarify the scenario. And let's do it in the coming session, just to practice a new scenario and to correct this misunderstanding. Again, it will be Dr. Sarah and Dr. Tanya, just to fix
Okay.
the information and yes, to
Okay.
practice the wrong and to correct the wrong. Okay.
Okay.
Thanks again, Dr. Hind. Be always with us to correct because
والله
sometimes
أخذ على قلبي بالعكس. I was happy that such
thank
a
you.
scenario came up لأنه
Yes,
uncertainty in the diagnosis
yeah,
is something tough, like, you know, to discuss.
yes, you're right, yes.
والله يسلم ايديك دكتور باسم. بغض النظر,
Bye.
at least يعني such scenarios when they are discussed in any practice session, they bring big benefit for everyone.
Thanks, Dr. Hind. Let's move to the next scenario. Don't leave us, Dr. Hind. Dr. Sarah, can you write the scenario, please?
Yes, in the group. I put it in the group.
I'll bring it. Dr. Tanya, can you read the scenario?
Yes. So you are the senior house officer looking after yesterday's on-call admissions for your team. One of these admissions is an 18-year-old woman, Miss Clayton. So she's 18-year, Miss Clayton, with no previous psychiatric history, who took an overdose of paracetamol yesterday. Paracetamol overdose. This was small, 16 tablets only, and her levels were undetectable 6 hours post-overdose. So she denies intending to kill herself and says she was confused. Today, the nurses report she has been verbally aggressive and swearing at staff and thinks they are trying to poison her. She wants to go home with her mother. Her mother has asked to speak to you with regards to taking her home. The mother feels that this was a one-off issue which won't happen again. Her daughter is far too sensible. Miss Clayton has not yet been assessed by a psychiatrist. Okay.
Okay, take 2 minutes or 3 minutes because this scenario a little long and
Okay.
yeah, a
Okay.
little difficult.
Yeah. So I will talk to the mother or Miss Clayton. Mrs. Clayton. Yes. Okay. to the patient.
No, to the mother, Mrs. Clayton, the patient, Miss Clayton. You can say Layla, or Laura, whatever, يعني, the mother. You will talk to the
The
mother.
mother, Laura. Okay, okay.
Laura, okay.
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 Okay, let's share the timer. Start.
Hello there.
Hello.
This is Dr. Akhtar, Senior House Officer to this clinic. Am I talking with Laura, mother of Miss Clayton?
Yes, doctor.
Okay. Mrs. Laura, we are here today to talk about health condition of your daughter. Is that okay with you?
Yes, doctor.
Okay, before proceeding further, may I know how much do you know about your daughter's health condition? And let me assure you, this will be totally confidential, this meeting conversation.
Okay, doctor. Well, my daughter was admitted to this hospital because she took an overdose of paracetamol. But I know she didn't want to hurt herself. We didn't know about this until 6 hours after she took it.
Okay, okay. So, may I know actually what is your expectation from our meeting today?
Yes, doctor, I want to take my daughter from here.
Okay, okay. I highly appreciate your feeling, Mrs. Laura. So, before proceeding further, may I know actually what happened exactly? Did she have similar attempt in the past, your daughter?
Yes, doctor. She had did it once a year and a half before. She take these tablets, and I know she didn't want to hurt herself. She just want to draw our attention.
I really appreciate your concern, Mrs. Laura, and I'm sorry for your daughter and the phase she's going through. So, may I know that did she write any suicidal notes before? I mean, at that previous attack?
No.
Okay, and this time, how many tablets actually she took? This
About
this attack?
16 tablets.
Okay, so did she take any alcohol or any other tablet with that?
No, doctor. She was not trying to kill herself. She was just
Yeah.
trying to draw our attention. So
Yes.
she took a small amount of tablets.
I highly appreciate your concern, and I can see how much you love your daughter and how you are appreciating her concerns. So just a few more questions. Actually, if you don't mind, may I proceed on? Okay, but I want to take my daughter from here. This is not the right place for her. Yes, yes. I will answer. Let me assure you, Mrs. Laura, I will answer your concern. My full attention will be with me. Just, I want to know the situation actually before proceeding to your concern. Is that okay? Okay, doctor. Okay. So, did your daughter lock the door from inside while taking those 16 tablets? No. Okay. So, did she call for your help after taking that, or did she feel like
No,
she's sorry?
no, I told you 6 hours passed before we know.
Okay, okay, okay. So after 6 hours, you know. So did you talk with her after that? That what she's thinking, that she's feeling sorry for what she has done?
She was sorry, doctor. She was really sorry. She didn't want to kill herself. I'm
Okay,
telling
okay.
you.
Yes, yes, yes. Okay. So may I ask you, why do you want to take her home now?
I don't think this is the right place for her. I think this is just a call for help. Um, she maybe she traveled in school or something, but I she didn't want to hurt herself.
So you think she has trouble at her school with her classmates?
Maybe, maybe because we are at home, we are okay. Nothing wrong has happened at home.
Okay, okay. So I think we can involve any social worker to involve with her and regarding that, if any problem with her at school. Is that okay with you?
Oh, but okay, when I talked to the nurses, they told me they will do a psychiatric assessment for her. This is right?
Yes, Dr. Mrs. Laura. Actually, I'm sorry to tell you that this actually, if this is, as you told, that it happened also before, and life has ups and downs, as you know, and we have to face this with sometimes some small extra help will work. So it's not about that mood doctors are very otherwise people that talking with, they are actually dealing with even with low mood, even with any kind of difficulties at life if we are facing. They can help us with, sometimes with talkative session, sometimes with medication. Are you getting that?
Okay, doctor. Okay, if this is important, can I take her and get her in another time or with appointment?
Actually, Mrs. Laura, I highly appreciate your concern. Your daughter need admission under our observation. So, may I explain you more about her condition so that you can understand the importance of her admission?
Okay, doctor, but they told me they don't need any drugs again. She is medically okay.
Actually, Mrs. Laura, I highly appreciate your concern, but whenever there is paracetamol overdosing is there, sometimes it could be not showing any sign symptom for 2 to 3 days. So, but it may have high risk with affecting silently. Maybe it can affect the liver, sometimes the kidney, even it can increase the blood acidity, even there could be a chance of easy bleeding with blood thinning more. So you see, so all of this complication may endanger your daughter's life, and I think your daughter is precious for you, and she's precious to us also. So we want to help her by admitting her so that she will be under our close observation. Are you getting me? Are you following me, Mrs. Laura?
Yes, you are asking me to leave here in hospital, and for
Yes,
how
Mrs.
long?
Laura.
For how long?
Actually, at least few days, we will regularly check up our liver and kidney function by taking the blood. So if it is coming to normal and we are feeling that she's totally away from the harmful effect of the paracetamol, we will discharge her definitely.
And what about the psychiatric assessment?
Yes, Mrs. Laura. Before discharging, actually, we will have an appointment with mood doctor with her. So she will have a sit with her, so that she can also, our mood doctor also help her, as I told you, with maybe low mood, maybe there's some problem, as you told, in the school. So sometimes, sometimes even talking sessions are helping, because she's very young and life has difficulties, right? So this mood doctor, they're helping them. Are you following me?
Yes, I'm following you. Okay, just you will check of her health condition, then we can go and then take an appointment with a psychiatrist.
And Mrs. Laura, I highly appreciate your concern. Actually, we will admit her. We will check her till few days, all the test results coming normal, and before discharge, we need to be evaluate her with the mood doctor. So that we can be totally worried free. There will be no worrisome that she is not going to do the same thing again. I think you also will be agreed with us, right, Mrs. Laura?
Yes, I agree, but if she tried to move, if she tried to leave the hospital and go home.
In that case, we have actually our legal department. They will take care of her. So don't worry about that. And she is with us. So we are talking with her. You also please try to talk with her with affectionate. So your daughter will also be comfortable to be stayed at hospital. Is that okay, Mrs. Laura? And we all are here to help her and also with you. I hope you will help us in this regard.
Okay, doctor. Yes, I will help you.
Thank you, Mrs. Laura. So, does your child smoke? Daughter smoke?
No, doctor.
Does she drink alcohol?
No, doctor.
Okay, so is she well supported?
Okay, time is up.
Yeah, time is up. Yeah, I believe this is very difficult scenario, Dr. Tanya. It's okay. You did great. And let's hear the comment from Dr. Sarah, then we will comment.
Okay. Scenario here talk about young girl. She is 18 years old. That means she has the autonomy. Um, and before mother talk to her, talk about her condition, should take consent from the patient. This is the first point. Second point, the mother want to take her daughter, and this is not allowed because she need psychiatric assessment before she go. She is medically okay, and nothing wrong with her after 6 hours of overdose. So she doesn't need medical assessment. She only needs psychiatric assessment. And if she insisted to go, this would put her under the Mental Health Act, and she will detained. Also, uh, also shouldn't talk about psychiatric assessment if she will go after this or not, because this depend upon the assessment, as this is the second time and she could do it again. Um, um, uh, just like this was the comments. Dr. Tanya did well according to the case of suicide, but these the points is important. They talk about it in the case. Okay, thank you, Dr. Tanya.
Yeah, thanks, Dr. Sarah, for new model suicide attempt. It was with the patient. Now we are talking with the mother about suicidal of the daughter. This is the new technique. So let's comment. Initially, the introduction and the permission is very important. You confirm or you ensure here that, or you assure her that the meeting is confidential, but you should tell her, yeah, permission from the daughter, because the daughter is 18. So still self-dependent and she had autonomy. So I agree, Dr. Sarah, you should assume that we have permission from, because if you didn't say that, you breach the confidentiality. Because might be not assumed you took the consent or the permission from the daughter, so you break the confidentiality of the daughter. Good thing to assure you have the confidentiality, but assume the permission because this is her daughter right to either to tell the mother or no. If you didn't assure that, mean that you break her confidentiality. So better to assume from the beginning that we have permission from your daughter to talk about her condition because it's sensitive point to talk about. What you know, she told you that she knows everything. And she assumed that her daughter is doing that for seeking attention. However, it was previously happened, so I doubt about this. As the Kusal said, this is the second time, so might be next time successful for suicide. So it will change our decision in the future. Expectation, she said, I want to take her home. Even this point or this concern, it's not her right because her daughter, the one who took decision for that. But you will not say that in the first time. Just try to know why she want that, then address every concern. You went to the circumstances of the intake of our paracetamol. Well, you asked about the previous attempt, and the notes, the alcohol, the door closing, the call for help. All these questions that were great to know about the circumstances and to decide if she has the seriousness of the suicide attempt or just seeking attention. If you know the circumstance well, you can decide by yourself. That's why I agree to ask this circumstance. Even the mother want to take her home, and she's insisting for this question. Yeah, you assure her that we love your daughter as you love your daughter, and she's precious for us. We want her to be assessed by the psychiatrist or the mood doctor. Why? No, it's not for something for her madness or something. No, it's just to assess her capacity and her mental health assessment in order to prevent further attacks of suicidal attempts. I want to take her home. Now you address her concern. Why you want to take her home? Dr. Sarah, can you repeat again the answer? Why she want to take the daughter home? Because of what?
This is not the right place for her. This was like a cry of help. She won't draw our attention.
Yeah, and she want to go school or something like that. I didn't understand. What is
This is
school?
I invented. This is I invented. This was
Okay.
not in the scenario, but
Yeah, yeah.
when Dr. Tanya insisted,
Okay.
I said that.
Okay. Yeah. So it's no, this is the proper place for her. This is the appropriate place for her. Yes. Against what she said. Why? Because your daughter need to be assessed by the mood doctor. Medically okay, but still, yes, I agree also, Dr. Tanya. There is delayed complication of paracetamol. Might be kidney, might be liver, might be bleeding. Even they are assuring now that the level is okay, but there is delayed side effect of paracetamol. So she needs to be assessed again by follow-up and monitoring and measuring the level and so on. And then to be assessed by the mood doctor. Yeah, you told her the nurse is saying yes, mood doctor. Yes, this is the decision of our expert team to be sit with the mood doctor to assess the mood to assess her capacity. Complication and observation, yes. Then address other concern. You have any other concern? No. I want still to take her home. I'm sorry. I'm afraid to say we have to sit with your daughter, and she is the one who will decide. And after assessment of our ward doctor, she will be either decided to go home or no. It's not. I mean, this is. I will not say that, but you will just assure her that this decision will be taken after the meeting with the mood doctor to assess her mental health assessment, okay, or mental health act by the mood doctor. Smoking, alcohol, yeah, any social support does she need for the help just to prevent any further attack? This is the scenario we'll go through or drive like that. Any question or any comments? What about the confusion and thoughts that the nurse will poison her? Yeah, this is
Yes,
important. That's why.
that's
Yeah,
why she need a psychiatrist assessment. Yes,
exactly. Yeah. So still she need to be detained and to be having a meeting with the mood doctor. I agree for that. Okay. Any other comment? Dr. Hind, yes, if you have some hidden point, you can address please.
This scenario, you remember Dr. Bassem common law اللي قلنا بدنا نحكي عنه,
Yeah.
the scenario of common law in past test.
Yes, yes,
This
yes.
scenario, yes, is talking about the common law. إنه أنت here the trick to convince the mother that her daughter better to stay in the hospital. I prefer to use some professional term. يعني I prefer to use because it's safer. We care about your daughter. We have a duty of care toward your daughter. تمام, to keep her safe, well treated. تمام. better إنه نستخدم we love your daughter أو those الأشياء يلي very far away from the management. لكن say to keep her safety, to take care of her, we have a duty of care. Those are a very nice and professional terms. They are very convincing for the mother. And no, we are here for the safety of your daughter. وحتى وقت قالت when she asked that why you want to take her home, this is not an appropriate, the mother said it's inappropriate place for her. I don't feel it's a good place for my daughter. Don't shift suddenly from she is saying it's not appropriate and you will go to the extreme and say no, it is the appropriate place. This is a big mistake in communication. You should acknowledge, you should be very soft. I understand. I can imagine that you are a caring mother and you want to protect your daughter and that you want to provide for her the best place. But I can reassure you that her presence in the hospital is in her best interest. And we are all here to ensure her safety, to provide her the best management. Try to be soft. Acknowledge the feeling of the patient. By thinking that this is an inappropriate place for her daughter is totally justifiable because she is a mother. So this has to be reflected by your words, okay? It's not that I'm answering. No, it is the appropriate place. This will be very harsh, okay? So acknowledge her feeling. Tell her that I understand from where you are coming, okay? And I can imagine your stress and that you are trying to protect your daughter and you are trying to provide her with the best environment. But I can reassure you that also this is our aim to keep her safe, to provide her best available treatment and manage her medically and also manage her mental status, okay? And this will be like an entry to talk about the mental health team. Don't mention the mood doctor, other unprofessional phrase. Now, never mention mood doctor. Whenever you want to talk about this specialty, mention mental health assessment. This is the professional terminology best to be used nowadays. It's not mood doctor, okay? Because here mood is mood. It means euphoria or depression. This lady, she has an element of psychosis. She has an element of suicidal attempt. We don't know. So mental health assessment team is a better expression for the management plan you want to provide to this patient, okay? And what else I want to say? So you have to convince the mother to be on your side and to convince her daughter to stay. So you have to show her how much things you are planning to do, your monitoring plan, the mental health team assessment, this kind of specialized team, they want to come and, like, you know, have a talk with her, have a chat with her, assess her competency, make sure that she's safe to be discharged. This word, safe to be discharged, is the key word of the whole scenario. My aim is to offer this patient a safe discharge, okay? So they will sit with the patient, they will have with her a chat, and we will try really to make sure that at the time when she leaves the hospital, she's completely safe. And she is, let's say that there will be no chance of complication, or the chance of complication is minimized as much as possible. So you will address the medical element and the mental health assessment side of the scenario. And if you were able to convince the mother that this is the best for her daughter, this time, yani by doing this, you have accomplished your task, okay? And the mother, there will be a concern of the mother in this scenario, that doctor, I'm scared if the mental health team has assessed my daughter, this will be documented in her file, in her medical records, and she will be deprived from some specialty in the college, from some jobs later on. Because we all know that any person had a stigma of psychological illness. For example, he cannot join the army, he cannot be a pilot, he cannot have, he's like, you know, not allowed to study some specialty in the university, or to get accepted for some jobs. So how you will address this concern?
Can be in this case, the doctor tried to say we have no guarantee of the result of the physical assessment will tell about your daughter condition. They didn't guarantee anything. I think we are not sure, so not to tell anything by
I agree with you, but the
by
first step,
confirmation.
yes, you are right. But the first step, which we are sure of, that if the mother and her daughter continue to argue against the mental health assessment, and we had to detain the patient under the Mental Health Act, the stigma مسكت بالpatient حتى قبل الأسسمنت. So this thing I'm sure of, right? So
Right.
this is the strongest way to convince
To
the mother and the
convince the
daughter
mother.
to stay.
Yes.
تمام
Yes.
ولا مو تمام؟
Yes.
Okay? This I'm sure of. لأنه مجرد إنه هي تعاند، ومجرد إنه هي تصير تطلع، ومجرد إني أنا أضطر to implement the Mental Health Act، انتهى الموضوع. لو طلعت إن شاء الله ملاك بالأسسمنت راحت عليها. تمام؟ So I have to be
So I will
very
use it.
careful.
Yeah, I will use it as a weapon.
عليك نور، وانت خلص انت هي مضمونة، لأنه هن بدو يعندوا الأم وبنتها. you have to convince them that I'm really sorry to tell you that in case you are too much worried about the future of your daughter, I really strongly recommend you to convince her to stay and to wait for the mental health assessment, because there is a chance that the mental health assessment clear your daughter and they permit her to leave the hospital. At that time, nothing gonna be recorded in her medical records, صح? And you will be able to admit her for any specialty in the university. She can apply for any job, تمام? But we cannot guarantee this for you if you continue to insist for discharge. تمام ولا مو تمام؟
Excellent. Not only
Yes.
تمام.
الحمد لله.
Yes.
حبيتوا الكومن لو؟ حبيتوا؟
Yeah.
Dr.
Yeah.
Hind,
Nice.
تمام؟
you remember
Okay.
you remember the case with the expression and with the terms they talk about, but there is something to tell. They talk about psychiatric assessment by this term, not mental health assessment.
مع
Is
شوفي
it
I
not a
agree with
jargon?
you. شوفي انت، انا ما اعتقد قبل هيك تناقشنا انا وياكي، بس للاسف انا عندي عاده مو حلوه، في ناس كثير بنتقدهم منهم past test. Don't trust everything mentioned in past test. ومع هيك بما انه انا عم بحكي كلمه كبيره، لانه past test is like لنقول يعني عامل مثل كتاب يعني الكتاب المقدس تبع MRCP، لكن still believe me, in case you want to believe me, don't trust everything mentioned. Trust the feedback. I saw feedback where the examiner considered المود doctor أو حتى السايكاتريك assessment. مشكلة السايكاتريك ممكن تعتبر jargon. فالmental health assessment is the safest professional term. It's never a jargon, and it is not confusing because you're not talking about the mood issues, and it's not irritating to the patient. تمام?
Okay.
So in that feedback, the examiner wrote that he preferred to use the mental health assessment team. Okay? And since that time, I'm really advising everyone to use it. Okay?
Yeah. Okay.
تمام?
Great, Dr. Hind. Yeah, great clarification. Thank you. I want to clarify when I said this is the appropriate place, because I heard that she's saying her place in school. That's why I said no, the hospital is the place. So I said it in this way.
هي اعتقد يعني هلا بالبدايه نحن ما كنا فهمانين شو قصه السكول، لكن she will
I
just
heard
tell
it
you
from Dr. Sarah. Yeah.
انه it is appropriate to be at home، ولا she feel يعني sometimes the mother feel more protective انه she will be able to protect her daughter، بس you have to change her mentality, correct the misconcept, and then she will agree with you يعني. بس
Yes.
guys
Yes.
احلى شيء بباست تيست بنتعلمه acknowledge. نحن من زمان كنا نقول كلمة I appreciate. It's not an appreciation, it's an acknowledgement. You should always acknowledge, understand ليه هذا البيشنت is talking like this, why this patient is thinking like this. دائما البيس النظارة تبع المريض، بيس النظارة تبع الأم، تمام؟ وtell her that everyone in your place would think like you. Every mother would feel, would love to be protective, تمام? And to take care of her daughter. فيعني حسسها إنه هذا تفكيرك مو غلط، بس let me help you. Let me tell you what we are planning for your daughter. Rather than using we appreciate, this will not change the equation. The appreciation is, you can use it once, twice, but when you acknowledge the feeling, when you make the person in front of you feel that you are not just telling things from your prospective point of view, or from your point of view, but you are also unable to understand why he is mentioning these things, why he's requesting this investigation, why she's requesting to take care. So you should first acknowledge, then
Yeah.
try to change.
Be
Appreciation
flexible.
can be used sometime, but don't keep it repeated with every concern.
Yeah.
Okay.
Like you mean be flexible with the question, don't be
flexible
strict.
و always make the يعني تعرف مثل اللي بيحسسك لما بتحكي انك
Yeah.
على حق، دائما حسس
Convincing.
هو على حق. يعني صح
Yes.
انت معك حق انك تاخذي بنتك على البيت اي ام، صح انت معك
Mhm.
حق تطلب CT وتطلب MRI لانك خايف على صحتك، بس هون في موضوع انت مالك منتبه عليه، وهو كالآتي كذا كذا
Yes.
كذا.
Yeah.
ما تحسسه انه هو غلطان بطلبه، ما
Yes.
تحسسه انه هو عم بيطلب شيء مو منطقي، ما تحسسه انه
Yes.
ما له حق، لا بالعكس. always agree with him, acknowledge his feeling, acknowledge his request. تمام.
Yeah.
But tell him the missing point which is not considered by him, and as soon as he will consider this point he might change his mind and he will agree
Yeah.
with your opinion. تمام.
I agree. Yes. And try not to answer in the opposite way of his question.
عليك
Like,
نور فورا، مع انه انت معك حق.
yes.
هلا انت وقت حكيت كلمتك ترى مو
Yeah.
غلط، لكن تخيل انا عم بقول لك it's appropriate to take وانت تقول لي لا it's appropriate to keep here. حتى ترى اذا بتحس انه
Yeah. It will be
العربي،
irritating.
تخيل واحد
Yeah.
يقول لك انا بدي اطلع تقول له لا انت لازم تضل. يعني هالاسلوب هذا غلط بالكوميونيكيشن،
Yes.
وبيولد نوع من العناد.
Argument more and more. Yes.
ايوه عليك نور، بيولد نوع من العناد. I'm really sorry for the Arabic talk.
No, no,
But
but
if
clear.
something is not clear, I can repeat.
No,
Okay?
no, it's so clear. Yeah. Thank you so much, Dr. Hind. Yeah.
I
Thank
understand.
you. Yeah. Okay. Okay. Thanks, Dr. Hind. Thanks, Dr. Sarah, Dr. Tanya. Nice to presentation and nice to scenarios with a lot of debate, but clear now after the debate, everything will be clear. Thanks. So, any question for this session before ending? Any comment? So I can end the recording, then we have the animation.
بس شغلة واحدة، الcommon law هو
Yes.
المرحلة when you talk about the common law, it is the stage before detaining the patient.
Yes.
تمام؟ يعني you are not applying any legal let's say law. ما في any legal law is applied whenever there is. That's why the title of the scenario was common law or detaining the patient under common law. When you keep the patient and you try to keep convincing him, but he is complying to your plan, not yet you didn't apply any act, you didn't implement any act. So this period called the common law. طبعا unfortunately أنا myself I tried to understand this 100% but I couldn't. لكن after reading whatever I could understand is what I'm telling you. All what we have discussed I was يعني pretty sure about, but
Yeah.
the difference between the common law, the time when you are applying the common law and the time when you apply the Mental Health Act and the Mental Capacity Act في gray zone حتى عندي أنا الصراحة. Okay? But at least from this scenario and from what I read, it is a stage before applying any legal step, let's say. Okay?
Okay.
It's this
Okay.
period called the common law or detaining the patient or keeping the patient under the common law. Okay? Until you decide and until you convince the patient, then you can proceed. Or the patient is convinced and then you don't have to apply any legal step. Okay?
Okay. Thank you, Dr. Hind, for more clarification. Thank you for attendance today. We'll end our recording. Then we'll have the animation. Thank you, everyone.
Thank you, Dr. Hind. Okay, thank you.
Thank you.
You are most welcome. Everyone.